Ivy, hello friends. Today we are going to discuss about the IVIG in ICU. This was also the question which was asked in DRNB critical care exam in 2024. So IV immunoglobulin is the blood product derived from the pooled plasma of 1000 to 15,000 individuals. The first reported use of immunoglobulin therapy was in 1952, where subcutaneous immunoglobulin was used to treat child with undetectable level of IgG and recurrent pneumococcal infection. So immunoglobulin therapy subsequently becomes standard of care for patients with primary antibody deficiencies. While initially adverse effects limited treatment to the subcutaneous and intramuscular route, subsequently changes in the manufacturing process lead to the production of the IVIG. So the proposed mechanism of action of IVIG. Within each indicated use, the IVIG has numerous potential mechanisms of action, and these can differ depending upon the disease process. This may include the interaction with the patient's immune system, such as blocking pro-inflammatory process or auto-augmenting anti-inflammatory one, or via direct interaction with the pathological target, such as bacterial toxin or transfer of antibodies. FAB receptor binding. FAB can neutralize autoantibodies and the pro-inflammatory cytokines and block activated complement component and adhesion molecules. It is also proposed to modulate antibody production and the maturation and the function of dendritic cell. Because of the large donor pool from each batch, many antigen and superantigen can be inhibited. Antigen-specific T cells are suppressed and mitogen-induced T cell proliferation is reduced. Now the Fc receptor binding. There are several theories for role of Fc receptors in immunomodulation. It is thought that giving IVIG results in the saturation of the Fc gamma receptor, resulting in less being available for autoantibodies. An alternate theory suggests the upregulation of the inhibitory Fc gamma 2b receptor on effector cells result in the decreased activation. So IV immunoglobulin causes the saturation of neonatal Fc receptor, which may shorten the half-life of all IV IgGs, including autoantibodies. Now the cytokine concentrations are altered with the increased anti-inflammatory and reduction in the pro-inflammatory cytokines. Now the next function is inhibitory effect on B cells. IVIG modulates B cells function and induces apoptosis of the B cell. B cells are characterized by the propensity to apoptosis. This effect is preceded by profound modulation of the B cell homeostasis, where IVIG induces downregulation of CD21 expression, promoting the generation of anergic-like apoptosis-prone CD21 low B cells. Now about the production, IV immunoglobulin sourced from the many healthy donors. The pooled plasma is obtained from 20% of blood donor and 80% of plasma. Each preparation contains the antibodies to specific antigen, natural autoantibodies, and anti-idiotypic antibodies. The large donor pool ensures the wide range of antibody to various bacterial and viral antigens. Unfortunately, this also increases the risk of viral transmission. To address this, each unit is screened for immunodeficiency virus, type 1 and type 2, hepatitis B and cell, and specific steps are used for viral inactivation and removal. The exact composition of each batch will vary between the products with different distribution of various subclass of IgG. IV immunoglobulin also contains the various amount of other protein, including albumin, IgA, IgM, and buffer agent. The therapeutic half-life is 2 to 3 weeks, but can vary based on the individual immune state. Now about the IVIG dose. Intravenous immunoglobulin is widely used as supportive therapy for many immunodeficiency disorder and as a treatment of different autoimmune disorder in two distinct dose regimens. The plasma IgG level reached in immunodeficient patients immediately following infusion of IVIG as a replacement dose, that is 300 to 500 mg per kg, that is 12 to 14 mg per it is higher when administered as therapeutic immunomodulator dose in autoimmune and inflammatory dose. In autoimmune and inflammatory disorder, and that therapeutic immunomodulator dose is 2 gram per kg. So the immunomodulatory therapeutic doses of IVIG may be infused as 5 daily doses of 400 mg per kg each. However, some studies found superior effect of IVIG when given as a single full dose rather than divided dose. For the maintenance of therapeutic response, repeated infusion of IVIG, usually 2 gram per kg at 4 to 6 intervals are needed. More studies are required to confirm the optimum dose and appropriate time period for IVIG treatment for induction and maintenance of immune response in this disease. The half-life of infused IVIG immunocompetent individual is 3 weeks. Now, the clinical uses of IVIG in following condition. As a replacement dose, we can give in, that is low dose. We can give in primary immunodeficiency disease, secondary immunodeficiency like B-cell malignancy and HIV infection. Uh, Immunomodulatory high dose therapy can be given in idiopathic thrombocytopenic purpura, acquired immune thrombocytopenia, autoimmune neutropenia, autoimmune hemolytic anemia, parvovirus B19 associated red cell aplasia, antifactor 7 anti-immune disease, and acquired von Willebrand disease. Then neuroinflammatory disease like Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, multifocal motor neuropathy, multiple sclerosis, myasthenia gravis, Lambert-Eaton syndrome, and stiff person syndrome. Then in some rheumatologic disease like Kawasaki disease, ANCA-positive systemic vasculitis, polymyositis, dermatomyositis, antiphospholipid syndrome, recurrent spontaneous abortion, systemic lupus erythematosus, juvenile idiopathic arthritis. Then some dermatological disorders like uh, toxic epidermal necrolysis, autoimmune skin blistering disease, streptococcal toxic shock syndrome, steroid dependent severe atopic dermatitis, and other conditions like graft versus host disease, antibody mediated rejection of the graft, and sepsis syndrome. Then about neurological conditions. Guillain-Barré syndrome is the acute onset sensory motor demyelinating polyneuropathy, which is characterized by the ascending weakness, respiratory failure, bulbar and autonomic dysfunction. It is caused by autoimmune damage to the peripheral nervous system, often triggered by infection. Approximately 25% of patients require admission to the critical care and mechanical ventilation. So, IV immunoglobulin is recommended for patients with GBS with significant disability, including those requiring or progressive towards mechanical ventilation. However, Miller-Fisher variant does not often require IVIG therapy. The recommended dose of IVIG is 2 gram per kg, started as early into course as soon as possible and given over 5 days. An initial course of IVIG is not advised if more than 4 weeks has elapsed since the time of diagnosis because of lack of suggested benefit. It is contraindicated if given 4 weeks after diagnosis because of lack of benefit. Whereas no randomized trial have compared IVIG with placebo, a recent concurrent review of IVIG compared with plasma exchange showed that IVIG to be equally efficacious at reducing disability score and time to unaided walking. In another study, although a lower serum concentration of IG2 Ig 2 weeks after infusion was associated with slower recovery and worse functional state at 6 months. Repeating the dose of IVIG Ig was not associated with any improvement in functional state. In addition, more adverse effects were observed in those receiving repeated doses, particularly venous thromboembolism. IV immunoglobulin has several benefits over plasma exchange, and it can be given without reliance on any specialist equipment or staff. This results in the shorter time to treatment and treatment being available more widely. In addition, patients treated with IVIG are also more likely to complete treatment course. However, there is no evidence of benefit with combination of IVIG or the plasmapheresis or crossover between the two. Now about myasthenia gravis. Myasthenia gravis is the autoimmune condition characterized by the antibodies against the polysynaptic nicotine acetylcholine receptor. It is frequently managed on outpatient basis with immunosuppression and acetylcholine esterase inhibition. However, patient can develop acute exacerbation during physiological stress and infection. A severe exacerbation may require admission to intensive care, usually either as a result of respiratory failure or severe bulbar dysfunction. Treatment with IVIG is recommended in patients with myasthenia crisis or before surgery to remove frequently associated thymine. The recommended dose is 2 gram per kg over 2 days. IV immunoglobulin is equally as effective as plasmapheresis, but the incidence of relapse may be reduced. The mechanism of action is unknown and the serum concentration of antibodies against acetylcholine receptor remain unchanged after treatment. Now about chronic inflammatory demyelinating polyneuropathy. Chronic inflammatory demyelinating polyneuropathy is a slowly progressive polyneuropathy characterized by the weakness of proximal muscle, impaired sensation, and a reflex. The proposed pathophysiology include antibodies, dysregulated activation of complement, and activated T cells. Treatment options include IVIG, plasma exchange, and steroids, and all of which have shown to be efficacious. However, for patients presenting with rapidly progressive symptom and weakness requiring intensive care admission, IVIG is preferred because of faster response time. The induction dose of 4 gram per kg is given divided over 2 sessions. An adequate response would be improvement in motor power graded by Medical Research Council score. IV immunoglobulin is often required as a maintenance therapy for up to a year. Acute disseminated encephalomyelitis. It is a condition with acute onset that is caused by autoimmune mediated demyelination of central nervous system. It is often triggered by viral infection. Characteristically, a prodrome illness is followed by fluctuating neurological symptoms, including encephalopathy, motor and sensory defects, and cranial nerve abnormalities. Critical care admission is often required because of encephalopathy and seizures. So the first line treatment is a high-dose corticosteroid, frequently methylprednisolone, 1 gram on day 1 for 3 to 5 days. And patients who have poor response to steroid can be considered for IVIG at a dose of 0.4 gram per kg for 5 days. A therapeutic response can take up to 3 weeks to manifest. A dose of IVIG can be repeated up to 3 times. A positive response would include improved modified Rankin scale score and reduction in seizure frequency. Now about the infectious disease. Toxic shock syndrome. Some Staphylococcus and Streptococcus species secrete exotoxin that act as superantigen to activate T lymphocytes. T lymphocyte activation lead to inflammatory cascade with high concentration of interleukin 1, interleukin 6, and TNF. This can result in development of staphylococcal and streptococcal toxic shock syndrome. Most patients develop antibodies throughout their adult life. As a result, both conditions typically present in the younger age group. However, antibodies deficient patient can also be affected. Streptococcal toxic shock syndrome is more common and often occurring in the presence of group A infection. The degree of systemic upset is frequently disproportionate to the infection in the presence of mild skin rash with failure to respond to standard antibiotic therapy. IV immunoglobulin is proposed to work through the passive transfer of superantigen neutralizing antibodies and inhibition of toxin production. So, IV immunoglobulin is recommended in patients with suspected or confirmed life-threatening streptococcal toxic shock syndrome who fail to respond to appropriate antibodies, including toxic supersectant agent like clindamycin and linezolid. Now, the next is Clostridium difficile. Clostridium difficile is the spore-forming anaerobic gram-positive bacillus. It leads to the production of endotoxin, that is type A and type B, and it causes the damage to the intestinal mucosal lining, leading to secretory diarrhea, inflammatory, and disruption of absorptive function. The presentation can range from asymptomatic carriage to the toxic megacolon, bowel perforation, and septic shock. So, IV immunoglobulin is considered for use in severe and recurrent infection despite optimal medical management with antimicrobial. While there is limited evidence for its use, the proposed mechanism of action include passive immunization and neutralization of endotoxin. The recommended dose is 0.4 mg per kg, which can be repeated once. Now, the next is rheumatological condition. Hemophagocytic lymphohistiocytosis is a state of pathological immune system activation involving macrophages and CD8 cells. It is often unrecognized cause of multi-organ failure and shock. Presenting features include fever, cytopenia over multiple cell lines, organ dysfunction, and raised inflammatory markers, particularly serum ferritin. Triggering agents include infection, hematological malignancy, and underlying rheumatologic condition. Treatment includes treatment of underlying disease process, immunosuppression with high-dose steroid, and the interleukin-1 receptor antagonist anakinra. So IV immunoglobulin is recommended at a dose of 2 gram per kg, which can be given in 2 to 5 daily divided doses. A positive treatment effect would be improvement in cytopenias, and the dose can be repeated at 14 days. Now, regarding hematological condition, vaccine-induced immune thrombocytopenia and thrombosis. Vaccine-induced immune thrombocytopenia and thrombosis is rare but potentially fatal complication of COVID-19 vaccination. The presentation can be between 4 and 42 days from vaccination. It is immune-mediated condition characterized by antibodies to platelet factor 4. Subsequent activation of platelets and coagulation system leads to thrombosis of both arterial and venous system in unusual sites such as cerebral venous sinus and splanchnic circulation. Definitive diagnosis requires all 5 criteria to be satisfied, and high index of suspicion is required in anyone presenting with new headache and neurological symptom after vaccination. So the diagnostic criteria are COVID vaccine within 4 to 42 days before the onset of symptoms, any venous and arterial thrombosis, thrombocytopenia, that is platelet count of less than 1,50,000, positive platelet factor 4 on ELISA, and markedly increased T. The treatment is complex because of thrombosis and bleeding tendency. So specialist hematology advice is advocate. Anticoagulation with the non-heparin anticoagulant such as argatroban is required. IVIG is used at a dose of 1 gram per kg and should be administered as early into disease process as possible. IV immunoglobulin causes reduction of antibodies to antiplatelet factor 4, prevents the platelet activation and ultimately leads to increased platelet count. Now the post-transfusion purpura. Post-transfusion purpura, it is a rare complication of platelet transfusion with incidence of 1 in 50,000 to 1 lakh transfusion. It presents with the falling platelet count typically 5 to 10 days after transfusion. And the bleeding is main complication. It is more common in female who have had previous pregnancies. Although pathophysiology is not fully understood, the proposed mechanism is transfer of anti-human platelet antigen antibody which leads to destruction of platelet. Diagnosis of post-transfusion purpura can be difficult or missed because of condition's rarity, elapsed time since the inciting transfusion, and other causes of low platelet in acutely unwell patients. Nevertheless, the incidence has decreased in the developed world since the introduction of leukodepleted blood product. The standard treatment is IVIG at 2 gram per kg over 2 to 5 days. Now the next is chimeric antigen receptor therapy. It is relatively new treatment for hematological malignancy. Patient can present to intensive care with the complication of treatment including cytokine release syndrome, neurotoxicity, hypogammaglobulinemia, and beta cell aplasia. IV immunoglobulin is given at a dose of 0.4 to 0.6 gram per kg per month to prevent subsequent episodes. Now about controversies, there are few notable conditions where IVIG is no longer recovered. For example, necrotizing fasciitis, it is no longer listed as an indication in the latest UK guidelines. There have been case series reporting improved survival and decreased ICU stay. However, there is a lack of high quality evidence to supporting its use in necrotizing fasciitis. Steven-Johnson syndrome and toxic epidermal necrolysis are life-threatening mucocutaneous conditions characterized by blistering and skin loss. Although they are thought to have underlying immunomechanism, there is conflicting evidence for immunosuppression with corticosteroid, cyclosporin, or IVIG. There is also debate around the use of IVIG in the group A streptococcal infection. Infectious Disease Society of America recommends against its use. However, in the UK, it is recommended at 1 gram per kg dose that can be repeated at 24 hours. IV immunoglobulin can be used for ANCA-associated vasculitis and catastrophic antiphospholipid syndrome. However, steroids and plasma exchange represents the optimal therapy. IV immunoglobulin can be used when plasma exchange is unavailable or its use is contraindicated. Now, regarding adverse effect, the incidence of adverse effect from IVIG is reported between 5% to 80%. However, many studies of adverse effect induced patient on long-term and low-dose replacement therapy. Whether this finding can be extrapolated to more general intensive care unit population is still being written. The adverse effect of IVIG can be classified as immediate or delayed. Immediate complication include flu-like symptom during infusion, hypotension, urticarial reaction, transfusion-related acute lung injury. Delayed reaction include increased thrombosis risk, aseptic meningitis, and acute kidney injury. Now, regarding adverse effect of immunoglobulin therapy, constitutional is pyrexia, flushing, chills, musculoskeletal pain, flu-like symptom, anaphylactic reaction, nausea, and diarrhea. Then also headache, migraine is common. Uncommon is septic meningitis, weakness, and the dystocia. Then in CVS, the adverse common side effects are hypotension, chest pain, and tachycardia. And uncommon side effects are arrhythmia and myocardial infarction. In respiratory system, the common side effects are cough and dyspnea. Uncommon side effects are trally pleural effusion. Then another uncommon side effects in context of renal side effects is hypothermia and acute renal failure. Common hematological side effects are positive direct Coombs test, and uncommon side effects are thrombosis, coagulopathy, neutropenia. The other uncommon side effects are transmission of blood-borne disease and serum sickness. Now, headache and other flu-like symptoms are most common adverse effect of IVIG treatment and have been reported in up to 80% of patients. The mechanism is unclear, but it may be secondary to interleukin and cytokines within IVIG preparation. Risk factors include high dose infusion at high rapid rate and previous headache with IVIG. The symptom resolve with the discontinuing infusion and supportive care. If symptoms are mild and respond to treatment, the infusion can be continued with close monitoring. Now, the next side effect is aseptic meningitis. Aseptic meningitis presents with the classical signs of photophobia, neck stiffness, and prolonged headache. CSF analysis shows the raised protein and lymphocytosis. However, CSF culture is negative. High dose of IVIG and history of migraine are the risk factor for developing aseptic meningitis. Now, the next side effect is TRALI, which is transfusion-related acute lung injury. It is a life-threatening complication of blood product transfusion. It is often present in first 6 hours of transfusion with acute respiratory failure, which is characterized by non-cardiogenic pulmonary edema. The treatment is supportive and frequently include mechanical ventilation. It is documented in several case reports after IVIG therapy. The mechanism of TRALI is thought to be caused by antibodies to leukocyte antigen, which are more frequent in women with previous pregnancy. One risk reduction strategy has been to obtain immunoglobulin product from male-only doctors. Now, the next side effect is posterior reversible encephalopathy syndrome, that is commonly known as PRES, which present as hypertension, headache, nausea, visual field disturbance, altered level of consciousness, and seizure. It is associated with characteristic changes seen on MRI in parieto-occipital region. So treatment includes stopping IVIG, lowering blood pressure, and management of seizures. Acute kidney injury after IVIG typically presents between day 5 to day 10. The cause is not fully understood, but the proposed mechanism include deposition of immune complexes in glomeruli, osmotic tubular cell damage, and transient vascular ischemia as a result of decreased renal perfusion. Risk factors include pre-existing kidney disease, advanced age, hypovolemia, and co-administration of other nephrotoxins. Now, infection. In 1994, hepatitis C infection was reported among recipients of IVIG. Although no other blood-borne disease have been reported in association with IVIG, they remain the theoretical risk. Prion infection have been transmitted via blood transfusion but are not known to have transmitted by IVIG. As a result of this perceived risk, British plasma is not used to make immunoglobulin. Manufacturers use donor screening and advanced purification technology to reduce the risk of infection transmission via IV. Thank you, guys.